Hello, coders. Today we're talking about cardiology surgery or cardiovascular surgery. So, the first thing I want you guys to keep in mind is don't forget, remember, at the beginning of each subsection, okay, in surgery, there's going to be an anatomical picture. On page 197 is the aorta. On page 198 is not just the heart, but also the blood flow through the heart. Page 199 are all of the major arteries and veins in the body. And then on page 200, there is a lovely anatomical picture of the right arm. That is the most common area for percutaneous procedures, otherwise than the femoral vein at the top of the leg. And also you'll see the lymphatic system pictures. You'll also see on page 200 the breakdown for hematic, lymphatic, mediastinum, and diaphragm. That will be in a slightly separate talk about that because there's not a lot of guidelines. It's a very small section, and I will do that separately. But it does happen at the end of cardiology. The other thing I want you to keep in mind is that if you're sitting for a credentialing exam like the CPC, when it comes to the questions, you're only going to get about 10 questions from each major section. So for instance, the 10,000s are integumentary, the 20,000s are musculoskeletal, but the 30,000s include respiratory, cardiovascular, hematic, lymphatic, mediastinum, and diaphragm. So you will not get 10 questions on respiratory, 10 on cardiovascular, 10, et cetera, et cetera. You will get 10 about them combined. But again, it's important to understand this. Now, if as we're going through this, there are terms that you don't know, those are the ones you want to go back to your medical terminology books, your anatomy books, or do some internet research. Because again, it's very important that you know the terms of this section to really understand what they're doing. So, like most of surgical procedures, the easiest ways to search for cardiovascular surgery is like the name of the surgical procedure, such as a pericardiectomy. Okay, you'll find that directly in your alphabetical index. The name of the anatomic site, you can look up heart, you can look up pericardium, you can look up artery, you can look up vein, you can look up aorta, you can look up the specific valves, or the name of the condition. There's going to be code specifically in here for dialysis. So we're going to see all three of those. So as we kind of go through, we're going to find main terms such as heart, of course, pericardium, pacemaker. We have our pacemakers in this section. Cardiology in general, implantable defibrillator, different ablations that we do, all the different valves. So the aortic valve, the mitral valve, the pulmonary valve, the aorta, of course, artery, vein, aneurysm, extracorporeal membrane oxygenation, and this is kind of like cardiopulmonary bypass, but it's more long-term, and we'll get into that when we look at the guidelines. Endovascular repairs. What we're seeing is we're seeing more and more percutaneous procedures. We go into a vessel and do a repair instead of slicing and dicing. We also can look under vascular procedures, catheter, central venous catheter. We have a separate section of just that here. Dialysis, hemodialysis, and transcatheter. All great main terms to look at. So let's start with our guidelines. So the first section is the pericardium. There are no guidelines for the pericardium. Easiest way to look those up are by the word pericardium. So what's nice is if you flip in your code book to page 204 and 205, you will see pictures of what we're going to be talking about, the pacemaker and the implantable defibrillator. So the first thing that we come across is the pacemaker system. Now, it's a pacemaker system which includes leads, a pulse generator that contains electronics, battery, and one or more leads. A lead consists of one or more electrodes as well as conductor wires, insulation, and a fixation mechanism. So the actual whole product is a battery pack, which is what they call the pulse generator, and the leads which connect into the battery pack. And at the end of the lead, there's a little hook mechanism. So when they put the lead, or it's a little probe, into the area where the patient needs help in their heart, it's going to stay there. Now, they tell us pulse generators are placed either in a subcutaneous pocket, created either in a subclavicular site or just above the abdominal muscles just below the rib cage. So, most common site is at subclavicular. It's under the clavicle. Remember, the clavicle goes from the shoulder to the sternum. So usually for women, they'll put it almost always in the subclavicular site because it's above the breast tissue. For men, they can do either. Now, leads may be inserted through a vein, transvenous, or they may be placed on the surface of the heart, epicardial. The epicardial location of leads requires a thoracotomy for insertion. So let's talk about both of these. 99 times out of 100, the patient is coming in for a transvenous pacemaker or implantable cardioverter defibrillator. I spoke to a electrophysiologist a few years ago, and he told me that in the 10 years at that point he had been working in my area, that he does anywhere between 5 and 15 pacemaker or ICD placements a week, usually pacemakers. He said out of 10 years of doing that, almost every week of the year, he has only had one epicardial placement. And he explained to me that epicardial placements are rare and they're used more for very specific conditions, or perhaps if a patient is going to get a heart transplant. It's not something that we see too often. So although we have codes for it, I don't want you to worry too much about it. However, because the most common is transvenous, what they do is when they create the pocket, they then bring the lead in through a vein, and then the vein leads to the heart, and they put it where it needs to be in the heart. If it's epicardial, it means on the outside of the heart. So that's when we need to do a thoracotomy. We have to cut into the thoracic cavity for proper insertion. Okay, but we have a couple different types of pacemaker systems. So we're going to talk about single, dual, and multiple lead. So a single chamber pacemaker system with a lead includes a pulse generator and one electrode inserted either into the atrium or ventricle. And again, that's dependent on the patient's condition. A dual chamber pacemaker system with two leads includes a pulse generator and one lead inserted into the right atrium and one lead inserted into the right ventricle. Okay. In certain circumstances, an additional lead may be required to achieve pacing of the left ventricle, which is known as biventricular pacing. In this event, the transvenous cardiac vein placement of the lead should be reported separately, okay, because it's an extra lead. So, first things first, what does the pacemaker itself do? What do these leads do inside of the heart? So the purpose of a pacemaker is to keep the pace of the heart. So people that have pacemakers have issues with the heart conduction system. So remember, the heart conduction, we're talking about the sinoatrial node and the atrioventricular node. It's that lub-dub. That's what keeps that lub-dub noise. That's what people are looking for when they're doing blood pressure. Okay, but the problem is people that have things like heart murmurs, where the heart skips beats or drops beats. The purpose of the pacemaker at that point is when there are drop beats or missed beats, the pacemaker sends an electrical shock into that area, whether again it's the atrium or the ventricle, depending on what the patient needs, to keep the electricity conduction going in the heart. Because remember, if the electricity conduction in the heart is not moving, the blood flow can't move through, because the nervous signals that we get from the SA node and the AV node is what tells our heart to contract and expand at its particular points. So this is something that the pacemaker kind of kicks in, and sometimes the patient doesn't necessarily even know the pacemaker is working for them. Okay, and that's the purpose of the pacemaker, is you shouldn't feel it. Okay, it's something that keeps the heart going when we have drop beats and skipped beats. Okay. However, we have a couple of new pieces of technology. Oop, I'm sorry. Okay. Oop. So, when it comes to the pacemaker systems, we also have what we call a leadless cardiac pacemaker system. This also includes the pulse generator with the built-in battery and electrode for implantation in the cardiac chamber via transcatheter approach, okay? So this is kind of, think like Bluetooth type technology. Okay, so instead of having to connect the lead to the battery pack, they're able to place both where they need to be. Again, the battery pack would still be usually in the subclavicular area. And then the lead is still implanted, but instead of having an actual connection between the two, there is that like Bluetooth type connection that's going to send the signal back and forth. However, you'll notice these all end in a T. Remember, anything that ends in a T is for temporary. They're category 3. The hope is that eventually this newer technology will make its way into the code book. Okay, so these are things that if you're in the field and you're coding for, be careful. You have to make sure the patient's insurance will pay for this. A lot of times this is where the prior authorization comes in. Can we do this for the patient? But if you look under these codes, what you'll notice is it will say something like sunset 2020. And the idea is hopefully by that year, it will have made its way into the regular CPT category 1 codes. Now, at the top of the next page, it goes on and it tells us about implantable defibrillators, okay? Ooh. And implantable defibrillators are different. So let's talk about what they are, and then we'll see that a lot of the information is almost exactly the same as a pacemaker. So where pacemakers are for things like heart murmurs, dropped beats, skipped beats, defibrillators are for people that have issues with fibrillation and flutters, meaning that instead of that nice lub-dub noise coming from the heart, it just kind of almost like has a muscle spasm effect where the heart just spasms. So blood is kind of sort of moving through the heart into the lungs and back to the heart, but it's not pumping properly. So what the defibrillator does is when the heart goes into that flutter or fibrillation, it sends a constant shock to the heart through the leads to get the heart back under control. And when people are getting that fibrillation and flutter, they will feel that. And they might feel shortness of breath, they might feel faint, they may even pass out. And that's what the defibrillator does, is that as soon as the heart starts going into that flutter or fibrillation, the ICD sends a constant shock until it notes that the heart is back into regular rhythm. So again, we're going to see a lot of similar things. They are different devices. They're used for different cardiac conditions. So like a pacemaker, the implantable defibrillator system includes a pulse generator and electrode. 2 general categories of implantable defibrillators exist. The transvenous implantable pacing cardioverted defibrillator, which is known as an ICD. That, again, it's implantable, and it's something that usually is mostly permanent. However, we have something called the subcutaneous implantable defibrillator, which is much newer, the SICD. And this is an implantable pacing cardioverted defibrillator that uses, again, a combination of anti-tachycardia pacing, low energy cardioversion, or defibrillating shocks to treat ventricular tachycardia or ventricle fibrillation. So the main difference between the two is the SICD is used for more short-term issues. So if someone goes into cardiac failure because of, say, an infection, they might use the SICD versus someone that has been diagnosed with ventricular fibrillation, then they might get the regular implantable one. Now, again, it goes on to tell us the subcutaneous implantable defibrillator uses a single subcutaneous electrode to treat ventricular tachyarrhythmias. Subcutaneous implantable defibrillators different from transvenous implantable pacing cardioverted defibrillators in that the subcutaneous defibrillator does not provide anti-tachycardia pacing or chronic pacing. So again, it's something that's more short term. Okay. It goes on to let us know that implantable defibrillator pulse generators may be implanted in a subcutaneous, infraclavicular, axillary, or abdominal pocket. So again, in this case, sometimes they will go closer to the clavicle, or sometimes they will go under the arm. Now, again, it reminds us removal of an implantable defibrillator pulse generator requires opening of the existing subcutaneous pocket and disconnection of the pulse generator from its electrodes. And again, a thoracotomy or laparotomy In the case of an abdominally placed pulse generator, is not required to remove the pulse generator. So again, normally we do not have to make a big incision into the body. Okay, same thing with pacemakers. They're relatively simple if the patient doesn't need it anymore. Now, the electrodes or leads of an implantable defibrillator system may be positioned within the atrial and ventricular chambers of the heart via the venous system, transvenously, or placed on the surface of the heart, epicardial, or positioned under the skin, overlying the heart, the subcutaneous. Okay, and then it reminds us that if we're doing an epicardial placement, we have to do it by thoracotomy or a thoracoscopic placement. Again, we have to actually make an incision in. Now, there's a lot of guidelines that are talking about all these different codes. I'm not going to read through all of this. And the reason why I'm not going to read through all of this is because this is something that the way you want to notate is going to decide how you want to deal with certain pieces of information. So this could be an area where if you really want to break it down into the different codes and what each and every code does, you might want to break out different colored highlighters or pens or pencils for underlining or circling. However, all of this is really just talking about what is the subcutaneous ICD, what is the regular ICD, what we do for removal. And so again, this is all just kind of describing each and every code that we're not going to get into, because I will let you do that on your own. However, for both the pacemaker and any of the implantable defibrillators or the SICDs, again, most of the time they can be done by transvenous extraction. If there's a problem, then on occasion they have to do a thoracotomy or a thoracostomy with the thoracoscopic surgery to actually remove it. But again, that's rare. It doesn't happen that often. Okay. Now, again, these batteries last about 8 to 10 years. So usually about every 8 years, the physician has the patient's pacemaker go under some testing. Now, it also goes under testing usually every year as well. Now, that all comes in medicine. So we'll talk about that in a different talk. However, what they do is usually the leads are still working just fine. They just need to replace the battery pack itself. So again, the same electrophysiologist explained to me that one of the weird things, and they don't really understand how it works, is when they put that battery pack in, whether it's a pacemaker or an ICD, that the area that is around it kind of smooths out. Usually when they implant something underneath the skin, there's a lot of scar tissue, but for some reason in the clavicular area, whether it's infraclavicular or subclavicular, this area, what it does is when they open up the scar, they can just pull out the actual battery pack and disconnect the lead from it, and then they can easily just slip in a new one, connect it, and sew it back up. Years ago, we used to have codes for that specific thing. But however, we do not code now for the opening of the skin pocket. We now only code for what are we doing. We're replacing the actual battery pack versus we're replacing the battery pack and we're opening the skin. And the reason is because it's really easy to get into that area, remove it. However, we will have codes for if the original area is no longer viable, whether there's necrotic tissue, dead tissue, or too much scar tissue, we can move where the battery pack is, and then that can be another code. So again, we need to know first, is this an initial, or is this a repair or a replacement or an upgrade? If it's an initial, it's going to be in one section. If it's a repair or an upgrade or reimplantation, then we're going to have other codes for this. And as you can see here, here it says repositioning of pacemaker electrode and implantable defibrillator electrode or left ventricular pacing electrode. Again, this is just more information going into what codes go with where. And you'll see device evaluation codes, they all start with 9s. Those are in medicine. So when we implant a device in the body, Most of the time it's going to come from surgery, but when we have to program, reprogram, tune, retune devices, that's all going to come from medicine. So keep that in mind. Now, again, there's more guidelines that go into which codes use what and the different testing that matches up with these. And again, this is something that you should read through and you should make your own decisions on how much information, because there's a lot of information here. But then you'll see underneath, this is where we get our table. And you can use the table or not use the table. If you like the table, then use the table. This might be a page you want to tab separately so that you can easily get to it. However, again, you can look under pacemaker or implantable defibrillator and you can find all of these codes. So keep that in mind. The tables in the book are there to help you. As we continue on, there are a couple definitions. So they remind us the differences between a single lead, a dual lead, and a multiple lead. Again, single lead goes in one chamber, dual lead goes in two chambers, multiple leads go in 3 or more chambers of the heart. And again, the first thing that you'll notice is these first codes, 33202 and 33203, are insertion of the epicardial. And then when we get to 33206, we get to insertion of the permanent pacemaker with a transvenous electrode. And again, we would go under pacemaker. Is it atrial? Is it ventricular? Or is it both? Again, if it's more than atrial or ventricular, if we're doing that biventricular pacing, that's a separate code. So if we add a third lead, we have to add another code on. Again, this is what the temporary pacemaker looks like. A lot of times this is going to be done in the hospital, in a facility itself. And again, what are we doing? Are we inserting or replacing it? What specifically are we doing? We can see right here, 33212, insertion of a pacemaker pulse generator only with existing leads, or with dual leads, or with multiple leads. Okay, so again, we have the initial insertion, which is a 33206 to 33208. But when the patient comes back 8 to 10 years later, what are we seeing? What are we doing? Are we just inserting the pulse generator? Or are we repairing or replacing the system? And again, you'll see here, if we just have to fix the electrodes, again, sometimes it's a couple years in and it's not the battery pack, it's the electrodes. So again, we can insert new ones, we can repair them. So again, we have to be careful because these are repairs of either or. So, this is one thing to kind of keep in mind to make sure we're always reading the full description. Now, again, I want to show you this code right here, these two codes, 33222 and 33223. These are for relocations of the skin pocket. So when we're going back in, whether we are just replacing the pulse generator, just replacing the leads, if we're replacing everything, if we're upgrading, all of those include the opening of the skin pocket. Okay, but if we're relocating, moving the skin pocket, then we can code separately for it. And again, sometimes it's because of necrotic tissue or infection or scar tissue. Again, we even have a repositioning code that you can see here. So again, what are we doing when we're dealing with pacemakers and implantable defibrillators? So are we doing the original insertion? Are we doing a repair? Are we doing an upgrade? Are we doing a repositioning? Are we doing a relocation of the skin pocket? What specifically are we doing during that session? Now, the next set of guidelines starts with the electrophysiologic operative procedures. So these are surgical treatments of supraventricular dysrhythmias. So again, remember, dys means bad or poor. When we're talking about rhythmias, this is basically pertaining to bad or poor rhythms. So what we're doing here is we're doing what we call tissue ablation, disruption, and reconstruction. And what we do here is we basically figure out where the issue is, where the dysrhythmia is coming from on the heart, and we do an ablation. We actually seal that area of tissue so that it doesn't overact anymore. So as it tells us, it can be accomplished by many methods, including surgical incision or through a variety of energy sources, radiofrequency, cryotherapy, which is cold, microwave, which is usually hot, ultrasound, or even laser. Lasers can be hot or cold. So again, these procedures were specifically dealing with the different ablations of the part of the heart. Now, what we're going to see here is with or without cardiopulmonary bypass. So what we're looking at here is what are we doing, and is it considered limited or extensive? So it tells us that the excision or isolation of the left atrial appendage by any method includes stapling, oversewing, ligation, or application is performed in conjunction with the atrial tissue ablation or reconstructive procedures. It is considered part of the procedure. So again, we have to know what's included in these codes. Now, again, we have a set of codes that is when we do not use cardiopulmonary bypass, and we have a code that the codes that do use cardiopulmonary bypass. Remember, cardiopulmonary bypass is basically when we put the person on a heart-lung machine. And so while they're under surgery, the machine itself is taking the blood out of the body, keeping it warm, spinning it, it is oxygenating it, and then putting it back in the body. So we have two major definitions here. Okay, we have limited, which includes the surgical isolation of triggers of the supraventricular dysarrhythmias by operative ablation. So again, these are the areas that we found previously on testing, and isolate the pulmonary veins or other anatomically defined triggers in the left or right atrium. Okay, so that's what is considered limited. Okay, so we deal just with the trigger that's in the pulmonary veins or other triggers in the left and right atrium. Okay, however, extensive includes everything in limited and additional ablation of atrial tissue to eliminate sustained supraventricular dysarrhythmias. Okay, so again, where are we? So this must include the operative ablation that involves either the right atrium, the atrial septum, or the left atrium in continuity with the atrioventricular annulus. So extensive, we're doing more ablations in a larger area. So again, when we look at this, we have, this is without cardiopulmonary bypass, 33250, and then with cardiopulmonary bypass. And again, you can see pacing and mapping. We yet again have another medicine code. Remember, cardiology is in two major sections. It's in surgery, it's in radiology, and it's in medicine. So we have a lot of things that can be linked together during the same procedure between surgery, radiology, and medicine. Now, there are no guidelines for the patient-activated event recorder. This is something that's usually done for anywhere between 30 to 90 days, usually around 90 days. And the purpose of this is that when patients go to the cardiologist or go to the hospital, they don't always feel what they're feeling when they're at home, when they're at work, when they're doing their daily duties. So what they do is if the patient's having different types of complications with their heart during their daily life, and it's not happening in the doctor's office, they might implant this to see what happens. And so when the patient feels a cardiac event, they have a little button they can push that will start the event recorder. And then when the event is over, they push the button again, and that information then gets sent when they get to an activation point like a Bluetooth or Wi-Fi connection to the doctor to let them know. Because again, a lot of times heart conditions are not always easy to find. Some of them can even be positional, where if a patient is standing up, they're fine, but if they lean over, then they have a problem. So again, it's trying to figure out where the problem's coming from. So we have an implantation and we have a removal. Now, when it comes to the heart and great vessels, so this is really dealing with the major cardiac procedures, again, as it tells us, that may require simultaneous cardiopulmonary bypass insertion of a cannula into the venous and arterial vasculatures with support of circulation and oxygenation by a heart-lung machine. And the reason why is because mostly when we're dealing with the heart, the great vessels, which is the vena cava and the aorta and all of the different valves inside the heart, we have to clamp off areas so that we don't have blood flowing through so we can actually perform these procedures. So cardiopulmonary bypass takes over that. So we can actually clamp off an area. We can actually stop the heart and allow the patient to continue to be sustained on cardiopulmonary bypass while we do these procedures. Okay, and the biggest thing is again, we need to know with or without cardiopulmonary bypass so that we get to the right set of codes. Now, the first set of codes for the cardiac valves is for the aortic valve, and they go in basically alphabetical order. So we have what we call TAVRs and TAVIs. So these codes 33361 to 33366 are used to report transcatheter aortic valve replacement, TAVRs, or transcatheter aortic valve implantations, TAVIs. So again, what we're doing is we're making procedures smaller. We're going in through veins, through a catheter, or through an artery to be able to actually go into the aortic valve and replace it without slicing and dicing the patient's chest open. Okay, so this is what we're doing. We're going through a catheter to do this. Now, as it tells us, TAVR and TAVI requires 2 physician operators, and all components of the procedure are reported using modifier 62. So if you have a surgeon who does these procedures, what they do, every part of the procedure, every different type of procedure they do for the patient during the surgery can be coded with a modifier 62 on both sides for both physicians. Okay, now these codes also, this is important, what does it include? It includes the work when performed of a percutaneous access, placing the access sheath, balloon aortic valvoplasty, advancing the valve delivery system into position, repositioning the valve as needed, deploying the valve, a temporary pacemaker insertion for rapid pacing, and closure of the arteriotomy when performed. Okay, so these include both an open arterial or a cardiac approach. And again, we try to do the transcatheter. So what they're saying, all of that is included. So actually accessing the area through an artery or a vein, and everything that we do to perform that surgery is included. They also tell us that angiography, radiological supervision, interpretation to guide TAVR and TAVIs are included in these codes. And that's because a lot of the times what's happening is the patient is in a surgery room where above them is an X-ray machine. And what they can do is instead of taking pictures, they can have a live feed of the X-ray machine going to a monitor. And they can actually, as they're going in, part of this is going to have metal, and they can see exactly where they're going through the X-ray equipment, okay? But here is the issue. Diagnostic left heart catheterization and supravalvular aortographies should not be used with TAVRs and TAVIs. So they're telling us these codes should not be done together in the same surgical session, okay? So for these codes, again, all the things that are included is the contrast injections, the angiography road mapping or fluoroscopic guidance for the TAVR TAVI, the aorta and left ventricular outflow tract measurements for the TAVR TAVI. So again, being able to use contrast, seeing where we're going, looking at the flow of blood through. And then post-TAVR TAVI, the aortic or left ventricular angiography. All of this is included. However, a diagnostic coronary angiography may be reported separately if, now, I'll tell you right now, this information right here is very similar to what we're going to see in radiology and then again in medicine. So again, we always want to make sure that we're reading the guidelines so we understand the codes. So it can be reported if no prior catheter-based coronary angiography study is available and a full diagnostic study is performed, or a prior study is available but documented in the medical record as the patient's condition has changed with respect to the clinical indication. There is inadequate visualization of the anatomy. There's a new clinical change. And if we are going to code it, it tells us that we have to code it with modifier 59, saying it's a separate and distinct service from the TAVR TAVI. Okay? So again, it's telling us basically we can do this if the patient's never had the study before, or if the previous study shows something different from what they're seeing now. If they couldn't see the previous study, again, maybe it was 15, 20 years ago, and the film isn't that great. Or there's a change during the procedure where they see something and they go, we need to investigate that more. Now, they remind us other cardiac services may be reported, and percutaneous coronary interventional procedures are reported separately, and those are from the medicine section. Now, again, when it comes to the codes themselves, what specifically are we doing to the valve itself? And how are we getting there? What's the approach? So, for instance, if you look on page 211, we can do femoral artery, we can do axillary, iliac, transaortic, transapical. So again, what are we doing with this section? Now for the mitral valve, again, very, very similar guidelines. These are called TMVRs. And the biggest thing that they tell us is 33419 should be reported only once per session. So that's important to know. So it tells us that these codes 33418 and 33419 include the work when performed of percutaneous access, placing the access sheath, transeptal puncture, advancing the repair device delivery system into position, repositioning the device as needed, and deploying the device. Also, angiography, radiological supervision, interpretation, performed to guide the TMVR are included in these codes. So again, just like for our aortic valve, the mitral valve is going to include getting to the area by whatever means they would like, whatever approach they're going to use. It includes all of the radiological imaging and supervision. Now, again, they remind us the diagnostic right and left heart catheterization codes should not be used with 33418 and 33419. Okay, so this is what is included. Again, contrast injections, angiography, road mapping, and fluoroscopic guidance for the transcatheter mitral valve repair, left ventricular angiography to assess mitral valve regurgitation, right and left heart catheterizations for hemodynamic measurements before, during, and after TMVR for the guidance of TMVR. And that right there is the reason why we cannot code right or left heart catheterizations with these codes, because the TMVRs include the catheterization to look at the measurements of blood flow in the heart. So again, we have to be careful what is included. Now, they can be coded separately, again, if there's no prior study, or if a prior study is there, but again, we cannot visualize the anatomy or pathology, something has changed clinically, or there's been a clinical change in the procedure. So again, we have to be careful. In general, we cannot code these catheterizations unless it fits underneath one of these issues. Again, we would append modifier 59 to describe this as significantly and separately identifiable from the procedure itself. And it goes on to remind us that, again, we will use cardiopulmonary bypass. And again, we can go through a percutaneous, or we can do an open peripheral or central bypass. So again, how do we want to get? What is the approach of the surgeon for this? So again, 33418 is percutaneous. 33419 is the add-on for an additional. And again, as we go through, what are we doing specifically? The tricuspid valve does not have any guidelines. But again, if it's an issue with the tricuspid valve, there are 5 codes. It's going to be one of those. The pulmonary valve, again, has very, very similar guidelines. Code 33477 is used to report transcatheter pulmonary valve implantations, TPVIs. Code 33477 should only be reported once per session. Code 33477 includes the work when performed of percutaneous access, placing the access sheath, advancing the repair device delivery system into position, repositioning the device as needed, deploying the devices, and then goes on, angiography, radiological supervision, interpretation, etc. So all of these are included. And again, reminds us that it includes all cardiac catheterization, intraprocedural contrast injections, fluoroscopic radiological supervision, interpretation, imaging guidance performing. So this is all inclusive in these codes. But again, there's a but. However, again, they're giving us some specific information about different valvuloplasties itself. They're reminding us that there are medicine codes that we may use at the same time. But again, what's included? The injections, angiography, road mapping, and guidance. Pulmonary conduit angiography for guidance because we're dealing with the pulmonary valve. Right heart catheterization for hemodynamic measurements before, during, and after TPVI. So again, this is why they are not usually coded separately. However, we can do a catheterization code if there's never been a prior study, or if there's been a prior study, but again, we can't visualize the anatomy, the condition has changed, or it changed during the procedure. And again, just like all of these other valves, we can start with mitral valve. You can look at mitral valve, what are we doing to it? Pulmonary valve, what are we doing to it? And again, it reminds us if we can code for the cardiac catheterization, again, we still use modifier 59. So again, we have to be careful. So these are all what can be reported when performed. So when they give us this information, they're telling us, listen, be on the lookout because sometimes you're going to have to use these codes in addition to. That's one of the reasons why cardiac surgery can be so confusing and overwhelming. It's because what we see a lot of the time is all of these other things that we could code with it, but again, it's all situational. So we want to be careful, what can we and what can we not code with these? And again, how are we getting there? What's the approach? Percutaneous, open, or central bypass? Now, the next set of codes is a very, very common set of surgery. These are what we call CABGs, coronary artery bypass grafts. And what we're doing here is we are usually taking a vein from the leg, the saphenous vein. We are harvesting that from the leg. We are cutting it up and we're making reconnections of the heart because the coronary arteries, the arteries that feed the heart muscle its blood supply, have an issue. Whether it's a stenosis, where it's collapsing and hardening on itself, or a fatty plaque buildup, or after a myocardial infarction. But I want to show you this. So there are two ways to get a vein and or artery out of the body. First is an open procedure, slice and dice and remove. But we can do 33508 in addition to the procedure, which is the endoscopically video-assisted harvesting. So if they talk about the doctor using any type of video assist or using any type of scope to get to the artery or vein, we better make sure we add this code on, otherwise we don't get paid for the endovascular. So we have three sets of codes, okay? The first set is venous grafting only. Second set is add-on codes for venous and arterial. Third set is arterial. So these coming codes, 33510, 33516, are for venous grafting only, okay? These codes should not be used to report the performance of coronary artery bypass procedures using arterial grafts and venous grafts during the same procedures. We're going to see the next set of codes for that, okay? So these codes are just vein only, as it says in the standalone code. However, what's included? Procurement of the saphenous vein is included in the description for work for 33510 to 33516 and should not be reported as a separate service or co-surgery. To report harvesting of an upper extremity vein, use 35500 in addition to the bypass procedure. Okay, to report harvesting of the femoral popliteal vein segments, report 35572 in addition to the bypass procedure. When a surgical assistant performs the graft procurement, add modifier 80 to 33510 to 33516. And for percutaneous ventricular assist device insertion, removal, and repositioning, we go to 33990 to 33993. So a couple things that are included here. Number one, the saphenous vein, which is the most common vein that they go for this procedure, is included in the work. So in the surgical report, they have to tell us what vessel they used, whether it was an artery or whether it was a vein, which artery, which vein. It has to be in there, and that's how we make sure. So all of these codes include the saphenous vein. If they have to use another vein because maybe this is their second or third procedure that they're getting done, then we do have separate codes that start at 35500 that can assist with other veins that we might remove from the body. Again, those are vein only. As soon as you start talking about veins, and those are not these codes. So again, this is one venous graft. So this would be code 33510. Right here, because there are 3 grafts and they're all venous, 33512. So again, you can see it's feeding from where the coronary artery receives its blood up to the aorta, because the coronary artery that's here is blocked for some reason. Now, one of the things that always has got me about this section is that they do describe the 2 sets of codes you need, but they don't put them in the correct sequencing order. Remember, although when we talk about sequencing, we're normally talking about ICD-10, it's also important in CPT. So they tell us the following codes are used to report coronary artery bypass procedures using venous grafts and arterial grafts during the same procedures. These codes may not be used alone. To report combined arterial venous grafts, it is necessary to report 2 codes. 1, the appropriate combined arterial and venous graft, and 2, the appropriate arterial graft code. And you'll notice that up here I put 1 arterial graft and 2 add-on for combo vein graft, because if you look at 33517 to 33523, they are all add-on codes, meaning they cannot go first. Although we do use both sets of these codes to describe this type of procedure, that guideline is in the wrong sequencing. Okay. However, it goes on. Procurement of the saphenous vein for graft is included in the description for work for 33517 to 33523 and should not be reported as a separate service or co-surgery. Procurement of the artery for grafting is included in the description for work for 33533 to 33536 and should not be reported as a separate service or co-surgery, except when an upper extremity artery, like a radial artery, it goes on, is procured. Okay, so we finally get to page 216 where the sequencing is correct. Now, it tells us, again, the following codes are used to report coronary artery bypass procedures using either arterial grafts only or a combination of arterial venous grafts. The codes include the use of internal mammary artery, gastroepiloptic artery, epigastric artery, radial artery, and arterial conduits procured from other sites. So the venous grafting only always includes a saphenous vein. The add-on codes for arterial grafts with venous grafts includes the saphenous vein. The arteries that are included are internal mammary, gastroepiloptic, epigastric, radial, and conduits. Okay, so again, we have to be careful. Read through the surgical report. What did they use? Okay, to report combined arterial and venous graft is necessary to report 2 codes. 1, the appropriate arterial graft code, and 2, the appropriate combined arterial venous graft code. That is the correct sequencing, and that is why I wrote it in my book. It goes on to remind us that if we use anything but those specific arteries and veins, we have to go and grab another code. So again, we have to be careful what is included in these codes, what is not included in these codes. And again, we can look up bypass graft and then you look up coronary, okay? Because we can do bypass grafts in all different areas of the body. As we continue on, again, there really are no guidelines for the single ventricle and other complex cardiac anomalies, but again, for those, we're going to look up specifically what are we doing to that particular part of the body. We also are going to see things like septal defects, the sinus of Valsalva, venous anomalies, shunting procedures, transposition of great vessels. These are mostly for congenital anomalies. When a baby is born with an abnormal heart construction, and they have to do reconstructions. So again, things like tetralogy of Fallot, where there's 4 different cardiac defects, will fit in to a lot of these and other types of anomalies that we see. So keep that in mind, that again, that's something that's kind of a specialized area of medicine, but you never know when you're going to come across that situation in your coding life. The next set of codes are for what we call endovascular repair of the descending thoracic aorta. So again, we have to remember that the aorta is like a candy cane, okay? So it candy canes up and over the left side of the heart and then comes down, continues through the thoracic cavity, goes into the abdominal cavity. And so the biggest thing that we need to keep in mind is this is the thoracic area. So again, we have the thoracic and we have the abdominal aorta. This is just the thoracic. Again, endovascular within a vessel. So these codes represent a family of procedures to report a placement of an endovascular graft for repair of the descending thoracic aorta. These codes include all device introduction, manipulation, positioning, and deployment. All balloon angioplasty and or stent deployment within the target zone for the endoprosthesis, either before or after the endograft deployment, are not separately reportable. So again, these are for conditions where we're repairing the thoracic aorta. Perhaps there was an aneurysm, so we have to repair the inside so that the thoracic aorta does not continue to bulge. Again, we can do these by a variety of different ways. We could do an open arterial exposure. Again, you know, it depends on the approach that the doctor wants to do. They can also do an open subclavian or carotid artery, approach as well. And so that's the big thing we need to keep in mind. However, fluoroscopic guidance is not included. We have to go to radiology for that. It goes on to tell us that again, if we're looking for angiography for this area of the body, we go to code 75956 and 75957 to include all the angiography of the thoracic aorta and its branches for diagnostic imaging prior to deployment of the primary endovascular device, including all routine components of modular devices, fluoroscopic guidance, and the delivery of the endovascular components, and interprocedural arterial angiography. Okay, so again, these are kind of paired together a lot of the times is what they're telling you. Now again, they also tell us other interventional procedures performed at the same time should be additionally reported. Okay, so that's all that's included. If we do anything other than what's included in these codes, then we cannot use these codes. Now, in respiratory, we have the lung transplantation. In cardiac, we have heart, and we have lung, and we have heart and lung, okay? So what we need to know is, are we doing just the heart with one lung, or the heart with 2 lungs? So, again, transplantation always has 3 components. First one is the removal, second is backbench, third is transplantation. So the removal, in this case, the cardiectomy or pneumonectomy, is again harvesting the allograft with cold preservation of the allograft. So that's removing all of the parts of that organ from the donated body and then making sure that it's staying stabilized, usually in a cold preservation. Then there's preparation. Now, the preparation of the heart and lung, or just the heart, is basically making sure that the patient has exactly what they need. If there's any extra skin or fat that might have been attached to any connective tissue, they're going to trim that all off. And so that's what they're saying. That includes the dissection of the allograft from surrounding soft tissues to prepare like the aorta, superior vena cava, inferior vena cava, and trachea. Okay. So again, what are we doing? Is it just heart in one lung, heart in two lungs? We also have the transplantation, which is putting it into the actual patient. Now, we now have some new codes for an artificial heart because it does work to some extent for some people. And so, again, these are completely new codes, and these are artificial hearts, okay, versus the rest of the codes are the donor cardiectomies and the heart and lung transplantations. Okay, so now we get to a big section of codes where, again, there's a lot of guidelines. I have not notated all of them because, again, a lot of them are very individual to how you would like to do it. In the field, what I would like to do is if I came up to a code, like if my doctor started billing for ECMO, the first thing I would do is I would read through all the guidelines and all the codes and notate what I need to know about each and every one of them. If you're studying for a credentialing exam, you want to read through all the guidelines, you want to make your notations. I hope you enjoy my notations, but you'll notice there are some sections that you may want to highlight that I haven't, and that's absolutely fine. Remember, this is your book. You can write in it as much as you want. I can honestly tell you, as someone who proctors credentialing exams on a constant basis, I get really concerned for students that show up without their code books at least being highlighted or highlighted and written in. This is your book. Make sure you understand what the guidelines are and where they are. So let's talk about a little bit about ECMO and ECLS, okay? So ECMO is extracorporeal membrane oxygenation. ECLS is extracorporeal life support. Okay, and as it tells us, it is a procedure that provides both cardiac and respiratory support to the heart and or lungs, which allows them to rest and recover when sick or injured. ECMO and ECLS support the function of the heart and or lungs by continuously pumping some of the patient's blood out of the body to an oxygenator, which is the membrane lung, where oxygen is added to the blood, carbon dioxide is removed, the blood is warmed before it returns to the patient. Okay, so again, very similar to cardiopulmonary bypass, but this is different. Okay. This is something that's a little more permanent, meaning the patient will not just be on it during a surgery. They might be on it for a couple of days, a couple of weeks, or even a couple of months. There are two methods that can be used to accomplish ECMO and ECLS. One method is veno-arterial extracorporeal life support, which supports both the heart and lungs. Okay. Veno-arterial ECMO ECLS requires two cannulas that are placed, one in a large vein and one in a large artery. Usually one's in the arm or upper chest and one is in the leg or upper thigh. But again, those can change also based on the age of the patient. Babies are going to be much different than adults. Okay. The other method is veno-venous extracorporeal life support. Veno-venous ECMO or ECLS is used for lung support only and requires one or two cannulas that are placed in a vein. So again, veno-venous is going to be used more for patients that are not as much for risk. These are services that basically help the body stabilize without having the body to work extra hard. So they'll do these for things like near drownings. They'll do these for patients that are having constant heart and respiratory failure for a variety of reasons. This is kind of a last-ditch effort to keep the patient's body sustained, but it's also a way to let the body rest after major procedures. So for instance, if someone does get a double lung and heart transplant all at once, they may be on ECMO for a couple days or a week afterwards, because ECMO will allow the patient to just be in a sedated state, maybe an induced coma, and allow a machine to assist the body in getting the oxygenation and the blood flow that it needs. So these are done for a large variety of circumstances, but they are done in, specialty areas. So again, you may never ever deal with ECMO, or you may deal with it all the time, depending on where you end up working. Now, there's a couple things we absolutely need to know. The services directly related to cannulation, initiation, management, and discontinuation of the ECMO and ECLS circuit parameters are distinct from daily overall management of the patient. The daily overall management of the patient is a factor that will vary greatly depending on the patient's age, disease, and condition. Okay, daily overall management of the patient may be separately reported using relevant hospital observation services, inpatient critical care, and management codes. Okay, so again, it's letting us know that the initiation, the management, and the discontinuation of these procedures do not necessarily have the overall component of a check-in on a daily basis, such as with an E&M hospital code. So again, they're just letting us know that there may be additional codes we have to use. Now, services directly related to ECMO ECLS involve the initial cannulation and positioning, removing, or adding cannulas while the patient is being supported. Initiation of the ECMO circuit and setting parameters is performed by a physician and involves determining the necessary ECMO and ECLS device components, blood flow, gas exchange, and other necessary parameters to manage the circuit. The daily management of ECMO and ECLS circuit and monitoring parameters requires physician oversight to ensure that specific features of the daily interaction of the circuit with the patient are met. Okay, so first thing is, it is the physician themselves who will actually place this inside the body. However, when it comes to checking in on the patient on a daily basis and making sure, ECMO is something that when someone's on it, most of the time, there is either like a perfusionist or a respiratory therapist or a specialty nurse who's going to be right there with the patient. One of my siblings is a respiratory therapist, and they used to do ECMO. And actually they still do ECMO, I shouldn't say that. And there would be times where they would spend the entire 12-hour shift in that room with that patient who was on ECMO. However, while they're in there making sure that the stats and everything stay the same, there's still physician oversight. And the physician is going to be checking in on the clinician's documentation and then reviewing it with the physician who's going to be taking over for the next shift. It goes on to tell us, though, that daily management of circuit and parameters includes management of blood flow, oxygenation, CO2 clearance by the membrane lung, systemic response, anticoagulation and treatment of bleeding, and cannula positioning, alarms, and safety. Once the patient's heart and/or lung function has sufficiently recovered, the physician will wean the patient from ECMO ECLS circuits and finally decannulate the patient. The basic management of the ECMO ECLS circuit and parameters are similar regardless of patient condition. Okay, and then it goes on to let us know that ECMO ECLS commonly involves multiple physicians and supporting non-physician personnel to manage each person's case. And so again, like I was just saying, perfusionists, respiratory therapists, specialty nurses, it depends on the state who does what. The ECMO specialists themselves will be there most of the time, but the physician oversights and they do check in with the patient. So if the physician does more than just place ECMO, if they do something else, they can also code separately. And of course, they can always code separately for the overall patient management, which would be an evaluation and management code. Okay. Now, it goes on to tell us that ECMO and ECLS daily management and repositioning services may not be reported on the same day as initiation services by the same or different individuals. And this is because when we are inserting this, it's going to include that day's daily management and any repositioning services that date. As soon as the next date happens, then you can code for any repositionings or any daily management services. But the first date, the initiation, includes everything that happens that date. If a different physician provides parts of the service, each physician may report the correct code for the correct services they provide, except noted. So again, if this is happening at the end of a shift change, we're going from one physician to another, they could have slightly different aspects that they're dealing with. So let's keep that in mind. So one of the big things that we're doing is when we're talking about replacement and repositioning, usually we're talking about the same vessel. If we do use a different vessel, we do have to be careful about the coding for that. We also might need to do extensive repairs. So one of the things I've done in my book is I've highlighted what we're doing. So I've highlighted the different initiations, the daily managements, the different, again, the insertions. What are we doing for the patient? And again, you can look up ECMO in the back of the book, or extracorporeal membrane oxygenation, and you can see what are we doing for the patient. Now again, I want you to see we have things like insertion of a central cannula by sternotomy or thoracotomy, birth through 5 years of age, and then 6 years or older. So there are some age components here, and there's 2 reasons. Number 1, children are generally smaller than adults, and number 2, babies are more complicated. And so if the child is under 5 years old, they're still considered in that infant style stage, and they're more complicated. They also need more specialized equipment because of their size. And again, this can be also done on newborn babies if there are very severe cardiopulmonary issues as well. And again, you'll see things like includes fluoroscopic guidance when performed. So again, there's a lot of include in these codes. These are big codes. Now again, we have another table. If you like the table, use the table. If you don't like the table, don't use the table. I like this table. I think it's really helpful. So this might be a page you want to tab that says, just ECMO. You could just put ECMO, and then oh, this is the one where the table's at. Or you could look up extracorporeal membrane oxygenation in the back of the book and get to this section as well. Now, along with those artificial hearts, we also have these cardiac assist devices. And these cardiac assist devices, there's a picture on page 227 that gives you a good idea of what these look like. These are also known as ventricular assist devices. They can be performed percutaneously or transthoracic approaches. And again, they could be intracorporeal or extracorporeal. So again, meaning the device can be physically inside the body or physically outside of the body, depending on what the patient needs and what the surgeon would like to do. Again, if we need to do like an open arterial exposure, we have separate codes. And if we'd have to do an extensive repair, separate codes. So what's included? Included in the removal of these devices are the removal of the device in the cannulas, removal of a percutaneous ventricular assist device at the same session as insertion is not separately reportable. So meaning if we're removing and replacing, we do not separately report it. For removal of a percutaneous ventricular assist device at a separate and distinct session, but on the same day as insertion, report 33992 append with modifier 59, indicating a distinct procedural service. Again, it tells you repositioning of a percutaneous ventricular assist device at the same session as insertion is not separately reported. Very similar to ECMO. If it's being done during the same session, we do not report it. But again, if the patient is back in their room and we have to reposition it, then that could be separately reportable because it's not necessarily during the same surgical session. Okay, so I'm going to finish here and I'm going to pick up the next lecture with the endovascular repair of the abdominal aorta and iliac arteries.